the launch of Dysport for aesthetic indication in Vietnam. I'm extremely honored, and I would like to thank Asia for inviting me here today to share with you this very important milestone. Now, I'm Dr. Lam Bilan from Singapore, and I've been practicing aesthetic medicine for more than 20 years. Now, the Able Face education program is the brainchild of Ipsen. It started in 2018 when Ipsen approached 8 global experts from all over the world to develop a very comprehensive and in-depth modules to educate local experts, to train other doctors, and also, most importantly, to deliver safe and effective Dysport injections for the patients. Now, the faculty grew to 12 globally in 2019, and this is a timeline of events as to what happened. In 2018, we formed the global faculty. We developed 14 modules, and we had the first division in 2019 when we developed 19 comprehensive and in-depth modules surrounding able botulinum toxin injections. And then in 2024, we did the second revision, adding onto the module new materials that we found because of the advances in aesthetic medicine, with even a chapter on ultrasonography, AI developments, and emotional anatomy. Now, these are the 20 modules that we have developed, spending a lot of time and effort. The history of botulinum toxin A, it's a remarkable journey, and it started way back in the 1800s when botulism was first described, and then the development of this very important molecule into one of the most important aesthetic and therapeutic treatments in modern medicine. Now, after years of clinical research, after years of clinical studies, botulinum toxin A injection has been proven without a doubt to be safe, effective, and evidence-based treatment for both aesthetic and therapeutic indications. Now, what about the story of Dysport? The story of Dysport is one of sustained innovation. Over 3 decades, Ipsen, the company that's all about science, has built a solid foundation on neuroscience, on manufacturing, excellence, on many, many years of clinical studies to prove that Dysport is safe, effective, and it also has got good onset of action, long duration of action, and most importantly, it is safe after repeated injections. And Ipsen is still continuing to invest in this neurotoxin therapy, to innovate and to share more things with us about this important molecule. Now, till date, more than 800 physicians have benefited from the Able Face education program. There are more than 1,300 peer-reviewed studies published. The therapeutic indications for able botulinum toxin are as follows, and the aesthetic indications is different in different parts of the world. In some parts of the world, it is indicated for treatment of glabellar frown lines, forehead lines, crow's feet, and even axillary hyperplasia. In Vietnam, the therapeutic indications are shown, and the aesthetic indications in Vietnam is only for glabellar frown lines. The slide hang. Can we move the slide? Yeah, okay. So what is botulinum toxin A? The bacterium Clostridium botulinum produces a complex that contains, sorry, you moved too fast. Yeah. It contains a complex which contains the core active 150 kilodalton active neurotoxin and the complexing protein. Now, the complexing protein protects the active core neurotoxin from a harsh environment in the stomach, but this complexing protein very, very quickly and immediately dissociate from the core active neurotoxin. One, it is injected into the tissue at physiological pH. So it is important for us to understand that the complexing protein plays absolutely no role in the action, the onset, the duration, the safety, the efficacy, and the diffusion of botulinum toxin A. Now, this active core neurotoxin, 150 kilodalton, is found in all botulinum toxin type A preparation, whether it is Xeomin, which is incobotulinum toxin, whether it is Dysport, which is abobotulinum toxin, or whether it is Botox, which is botulinum toxin. It is found in all botulinum toxin type A preparation. So, are all toxins the same? Now, as I've mentioned earlier, all botulinum toxin type A preparations contain the same 150 kilodalton core active neurotoxin. They all are derived from the horse strain of Clostridium botulinum. They all act on the SNAP25 protein, which inhibit acetylcholine release at the neuromuscular junction, thereby inhibiting muscular activity, thereby softening lines and wrinkles. Now, besides this, the difference lie in the preparation, the assay method used, and of course the absence and presence of complexing protein. Now, the complexing protein is present in abobotulinum toxin preparation and botulinum toxin preparation. That is, it is present in Dysports and Botox. The complexing protein is not present in Xeomin or incobotulinum toxin, which means incobotulinum toxin, aka Xeomin, is a naked protein. It only contains the 150 kilodalton core active neurotoxin. But remember what I said, the complexing protein plays absolutely no role in the onset, the duration of action, the safety, efficacy, and diffusion of the botulinum toxin type A preparation. All preparation contains human serum albumin, and the human serum albumin found in Xeomin, Dysport, and Botox will protect and stabilize the botulinum toxin type A, okay, when you inject it into the tissues, and it also prevents adhesion of the botulinum toxin type A molecule to the glass surface in the valve. So, are all toxins the same? The short answer is no. The difference also lies in the amount of active core neurotoxin that you found in each preparation. Now, we know that the approved dose for Dysports in glabella is 50 spirit units, and the approved dose for botulinum toxin or Botox is 20 units in the glabella, and the approved dose for Xeomin or incobotulinum toxin is 20 units in the glabella. We know that 50 spirit units of Dysport contains 269 picogram of core active neurotoxin, and 20 units of or Botox contains 181 picogram, and Inco contains the lowest, which is 81 picogram of core active neurotoxin. And therefore, at the approved dose of 50 spirit units of Dysport for the glabella, Dysport contains the quantity of core active neurotoxin required to maintain natural, durable, and long-lasting results. We are not saying that Dysport is better than the other preparation. We are telling you that at this 50 spirit units, at this amount of core active neurotoxin, we can maintain natural, durable, and long-lasting results. Now, the molecular potency of the toxin is dependent on the amount, the activity of the core active neurotoxin, and also on the affinity of this toxin to the neuronal membrane, and that's important for us to understand. So, are the units between the different preparation interchangeable? The short answer is no. Why is that so? Because the potency units of abobotulinum toxin or Dysport is unique to the preparation and assay method used, and the units are not interchangeable. Now, for those doctors who are first embarking to use Dysport for aesthetic indications, sometimes it's difficult because you try to convert the units for another preparation to Dysport. Now, you do not have to. At the end of this session, and thanks to Dr. Antau, we are going to show you how easy it is to just use Dysport on its own to inject the glabella, even your lateral canthal lines and your forehead lines, without having to convert the units. It's very, very easy, and I'm going to share with you later how you're going to do it. So let's talk about diffusion and spread. So what is spread? Now, spread is active and is fast. It occurs at the point of injection, and it is dependent on the injection technique you use and the injector. It is dependent on the volume you use. It is dependent on the speed you inject. It is dependent on the bore size of the needle and the direction you point the needle to. It is dependent on the depth of injection. So the bigger volume you use, the faster you inject, the deeper you inject, you're going to spread more. Now diffusion, on the other hand, it's slow and it's passive. It is a dispersion of the toxin from an area of high concentration to one of low concentration, and diffusion is the same for all botulinum toxin type A molecule. However, diffusion can be uneven if the area that you inject, the density of the receptors is different. Otherwise, diffusion is the same for all botulinum toxin molecule. Now, let's take an analogy. Sugar particles. Now, sugar particles are like toxin. If you put some sugar particle onto a flat surface, okay, presuming all the external variables are conserved, meaning diffusion and spread is the same, you sprinkle some sugar molecules onto a flat surface, the lesser amount of sugar molecules you sprinkle, the area it covers will be smaller. If you sprinkle a bigger amount of sugar molecules, the area it covers is going to be bigger. Now this is akin to the toxin molecular potency. It is akin to the area of clinical effect of the toxin. So what does that mean? Now, as I mentioned earlier, diffusion is the same for all botulinum toxin type A. Because diffusion is the same, therefore the area of clinical effect is dependent on the spread. And what I mentioned about the spread is dependent on you and I, the injector and the injection technique, and it is dependent on the molecular potency of the botulinum toxin type A preparation. And remember what I said, molecular potency is the quantity of the active core neurotoxin. It is the affinity of the toxin to the neuronal membrane. It is also dependent on the quantity. Therefore, if your speed is very fast, the volume is high, you inject very deep, your area of clinical effect is going to be bigger. So this explains the area of clinical effect. So some doctors are going to say, because of high molecular potency, the area is going to affect is going to be bigger. Now, if you are very precise, okay, when it comes to toxin injection, regardless which brand you use, whether it is Inco, it is Abo, or it is botulinum toxin, precision is king. And I will also urge you, because of this, when you're injecting toxin, you have to use a 0.3 mils of the syringe in order that you are very precise. Because in muscles, such as the corrugator supercilii, the procerus, the electrical line, you have to be very precise, and you have to make sure that the toxin is injected into the targeted muscles and it will flood the neuromuscular junction where you want it to go. And therefore, all botulinum toxin type A have comparable spread and diffusion, but the areas of clinical effect is different at approved doses due to the molecular potency and the amount of active neurotoxin, and I explained to you earlier. Now, Dysport's approval for the use for moderate to severe glabellar frown lines are based on multiple phase 3 clinical studies, and the safety, efficacy, and patient satisfaction is confirmed on a phase 4 open label trial, which is designed to simulate real-world treatment strategies. There are many, many studies. We named 4 here, but due to time constraint, I'm going to only share with you 2 very important studies. If you're interested, you can approach me at the end of this talk. I can share the rest with you. Now, the first study was published in 2009 by Brent. The study involved 158 patients who are randomized. The primary objective of the study is to evaluate the efficacy, safety of Dysport in treatments of moderate to severe glabellar frown lines, Dysport versus placebo. 158 patients, they were randomized in a ratio of 2:1 to receive either Dysport or placebo and the patients are followed up day 7, day 30, and day 180, sorry. Now the results show that the proportion of responders, in other words, responders who responded to the treatments from moderate to severe glabellar frown lines becomes no or mild glabellar frown lines, the proportion of responders at day 30 was significantly higher for Dysport versus placebo injections. This is investigator assessment, this is patient assessment. For investigator assessment, it's 90 versus 7.5%, which is statistically significant, and for the patient assessment, it's 76% versus 9.8%, which is also statistically significant. Now, the median onset, it's 3 days. In fact, 15% of patients show response within 24 hours, and 35% show response within 2 days. The median is 3 days. The median duration of action is 85 days. Now, the adverse events, they are mild to moderate. They all resolve without any serious consequences, and the adverse events were found to be comparable with placebo in type, frequency, severity. Now, this second study is a very, very interesting study. Again, it's a phase 3 multi-center open-label study of Dysport to show the safety, efficacy of repeated Dysport injections in the population. Very important, because you don't inject Dysport only one time, you have to repeatedly inject in your patients. We need to find out if it is safe. So there were 1,200 patients involved, more than 4,200 Dysport injections, up to 5 treatment cycles, and it's over a 30-month period. These are the results that you can see. We can see that the response rates varies from 80 to 91% for investigator assessment, and it varies from, you can see 82%, 73% to 82% for patient assessment, which are statistically significant. The median time to onset is 3 days, and the median duration of action is 88 days. Now, in fact, 2% of patients in cycle 1 and 7% of patients in cycle 7 have a duration of effect up to almost a year with Dysport treatment just one time. And this is a very, very interesting chart which I want to share with you. These are the adverse events that is found in these 1,200 patients injected over 5 cycles. The minimum interval is 85 days. Now, 72% of the adverse events were found to be not related to the treatment. 36% of the adverse events were found to be related to the treatment. Now, you take a look at these adverse events. Notice that the adverse events decreases in numbers with each successive cycle. Now, this is very interesting. It tells you that the adverse events improve with experience, improve with repeated treatment. So what does that tell you? We take a look at the eyelid ptosis from 30 cases in cycle 1 to 1 case in cycle 5. Why? Because, remember I shared with you, a lot of adverse events are injection technique dependent and injector dependent. So the injector realized that there's eyelid ptosis, so they use the finger to block the supratrochlear, supraorbital foramen. They inject slower, smaller volume to prevent spread of the toxin through the orbital septum, through the foramen, to affect the levator pulmonaris superiorus muscle, resulting in ptosis. The doctor also switched from 5 injection point to 3 injection point. So you learn from experience and mistake you have made, and you can see that the adverse events reduces, and it shows you that a lot of the adverse events is injection technique and injector dependent. And the conclusion tells us that Dysport is safe after injecting in multiple cycles. It doesn't cause any tachyphylaxis or cumulative adverse events, which is important. And these are the conclusion that you can see. Dysport is safe and effective to treat moderate severe glabellar frown lines with 50 units. Rapid onset, long duration, high patient satisfaction. No evidence of diminishing response when you repeatedly inject Dysport. It is safe, and there's no evidence of tachyphylaxis and cumulative adverse events with repeated Dysport injections. So these are the 2 clinical studies that I want to highlight to you. The slide is not moving. Now we're going to talk about practical aspects. Now, botulinum toxin comes in different vials, 500 units, 300, 125, it's not 150, sorry for the mistake, in a powder form. And the shelf life is 24 months if you remain unopened in the refrigerator 2 to 8 degrees Celsius. Once reconstituted, it remains stable for 24 hours in the refrigerator between 2 to 8 degrees Celsius. Now, depending on what you have, right, you want to dilute the powder with 1.5 mils of normal saline if it is 300 units, 2.5 it is 500 units. If it is 125, you're going to dilute with 0.63 mils of normal saline, not water for injection, not lidocaine, not hypertonic saline solution. Whichever dilution that you use, 1.5 for 300, 2.5 for 500, or 0.63 for 125, 0.05 mils of the solution will give you 10 units of Dysport. And that's very important for you to understand. And we should try to just dilute Dysport to yield this concentration and this dosage. 0.05 gives you 10 units of Dysport. Now, the different syringes. Can I have a show of hands here? What kind of syringe do you all use when you're injecting toxin? Regardless which toxin you use, who use 0.3 mils syringe? Can I have a show of hands? No one? Who use 0.5 mils syringe? No one? Who use 1 mil syringe? I have 1 hand, 2 hands, 3 hands. Okay, thank you very much. Now, I urge and encourage everyone, if you want to inject toxin, to use a 0.3 mil syringe. Okay, it is very important because toxin injection, if you want to get good results, is all about precision. If you're injecting big areas like masseter, like trapezius muscles, like calf muscles, you can use a 1 cc syringe, or even hyperhidrosis. For the rest of the face, I encourage all of you to use a 0.3 mil syringe. Now remember I said 0.05 mils will give you 10 units of Dysport, 0.1 mil will give you 20 units of Dysport, regardless of which syringe you use. But if you take a look at the 0.3 mil syringe, you can see there are 5 divisions. So 10 units, 5 division means 1 division will give you 2 units of Dysport. Similarly for the 0.5 mil syringe, 0.05 will give you 10 units. So each division will give you 2 units. But if you use a 1 cc syringe, the division is really very small. If you're not careful, you inject, instead of injecting 2 units, you'll be injecting 10 units. If you're supposed to inject 10 units, you might be injecting 20 units. That is the reason why this is the best, because you are very precise, and this is actually very cheap. Okay, the 0.3 mil syringe, regardless of which toxin you use, I highly, highly encourage all of you to use the 0.3 mil syringe. Okay, so it's very easy to understand. If the Gabella Frontline's approved units, 50 units, you do not think of it in any other formulation. You just understand it's 50 units for Gabella, for Dysport, it's 10, 10, 10, 10, 10. If you do not want, if the patient has got not so strong muscle, you want to have lesser effect on the muscles, you will inject, instead of 10, 10, 10, 10, 10, you inject 10, 10, 6, 10, 8, 6, 10, 6, 4, and so on and so forth. So it's very easy for you to remember. You don't have to convert from any other toxins, okay? Now, label indications. Dysport is approved in Vietnam for use on glabella. The dose recommended is 50 spirit units. The first dose is in the procera, in the muscle belly. Second dose, the head of the corrugator. And the third dose is at the tail of the corrugator, because it inserts superficially into the skin laterally. For the lateral canthal line, it's 30 units on each side, upper, middle, and lower canthal line. Okay, now for the forehead, the approved units is 30 to 40, depending, of course, on the muscle activity, depending on the lines you see. the maximum you should use is 90 units, but I urge you, for botulinum toxin injection, less is more. You use a dose that you think is sufficient for the patients, because what you inject, you cannot take it out. You always bring the patient back for review 2 weeks later, and you decide or not if you want to top up. Okay, that's very, very important. Now let's talk about facial expression. Now we know facial expression, it's a balance between the elevator of the face and the depressor of the face. The single elevator of your eyebrow is your frontalis muscles, and the depressors of the eyebrows, you have the corrugator supercilii, depressor supercilii, the orbicularis oculi muscles, and the procerus. And the eyebrow balance is all dependent on the balance of the elevator and depressors of the face. So facial muscles are mimetic muscles, and they're very special muscles. Why is that so? Because it arises from the bone and it attaches to the skin above. And when you do facial expression, what does it do? The muscles pull onto the skin, resulting in lines and wrinkles that occur at right angles to the direction of pull of the muscles. Okay, I'm going to explain to you what I mean later. So these are the various muscles you find in the face. Sorry, it's not moving. Can we forward the slide? Okay. Now we talk about patient assessment, different areas of the face. Now this is glabellar patterns. Now we know that the glabellar lines are contributed by a group of muscles which include the procerus, the depressor supercilii, the corrugator supercilii, the LLSAM, which is the levator levi superioris, echinacea muscles, and the nasalis muscles. Now, all muscles in your face do not work individually on its own. We need to understand that all the muscles interdigitate with each other. Some of the fibers interdigitate more, some less, and this is one important point that we need to know when it comes to botulinum toxin injections. It's not moving. Sorry, okay. So these are the various glabellar frown lines pattern. You can take a picture of this. Basically, these patterns are important for you to understand because it shows you the strength of the different muscles that forms the glabellar frown lines. Okay, so different pattern is because the muscles that contribute to the glabellar frown lines have different strength, and that's normal. Okay, so these are the different patterns. Now, let's take a look at the first example. If you take a look at this lady frowning, we know that the corrugator supercilii is stronger on the left side compared to the right. Why is that so? Because you can see she has vertical line that occur at right angles to the direction the pull of the corrugator supercilii. That's what I mean. Corrugator supercilii pull the eyebrow downwards and inwards, and the line occur at right angle to the direction of pull of the muscles. You have more lines here, which means the corrugator is stronger on the left as compared to the right. She also has a depressor supercilii. You can see the muscles here is stronger on the left as compared to the right. She also has got a strong procerus muscle because procerus muscle pull the center part of the forehead downwards towards the nose of the bridge of the nose, and you have a horizontal wrinkle that occur at right angle to the direction of pull of the procerus muscle. So she has strong procerus, strong corrugator on the left as compared to the right, and she has a strong depressor supercilii on the left. So what does that tell you? That tells you that when you perform treatment on patients like this, even if you put the standard 50 units in the glabella, when you bring the patient back for a review 2 weeks later, you might need to top up a little bit on the left side. Or if you decide you put less units on the left, 10, 10, 10, sorry, more units than 10, here maybe you put less, that's 6 units. So that's the reason why every patient is different. If I'm going to inject everybody in this room, the units I use, the sites of injection, the depth I inject is going to be different. Okay, so it's important for you to know how to assess the muscles. Now let's take a look at the second case. I'm going to waste a lot of time clicking. Okay, now this second case, you see when she frowns, she has a very short corrugator, and The line occurs at right angle to the corrugator. She has strong, short corrugator. She also has a strong procerus muscles, as evidenced by the horizontal line on her nose. So you have to treat the procerus, the head of the corrugator, and the tail of the corrugator. All right. She also has a depressor supercilii that is stronger on her right. Do you get what I'm saying? Okay. Do you understand what I'm saying? Now, let's take a look at this V-shaped pattern again. You see when the patient frowns, she also has a very short corrugator. She probably has a stronger corrugator on the left because you can see the line is stronger. She has a very strong procerus muscle because of this horizontal wrinkle. She also has a strong depressor supercilii on the left. So what must you treat? You must treat the corrugator. You might put less units at the tail end of the corrugator because if it's really short, you definitely have to treat 10 units for the procerus, and you have to treat the depressor supercilii on the left. Okay, that's how you analyze the muscle pattern. Now let's take a look at the next case. This gentleman, when he frowns, okay, at rest already he has static lines, all right? Which means he has got very strong corrugator because of static lines. Can we play the next video? Sherry, can we click on the... Okay, so you can see this lady, very long corrugator. Very long corrugator when she frowns. Okay, she has got multiple rows of low-lying forehead lines. The frontalis muscles is very strong. And you can even see the frontalis inserting on below the eyebrow. And that's very important for you to understand. Okay, I'll show you why later. Now, frontalis muscles interdigitate with your depressors, okay, i.e. your corrugator supercilii, depressor supercilii, orbicularis oculi muscles. When your frontalis muscles insert below your eyebrow, you have to be very careful because when you're injecting the lateral canthal line, you have to make sure you don't hit the frontalis muscles. Otherwise, the patient is going to have eyelid ptosis. Okay, so analyzing the pattern of contraction of the muscles in the face is very important, and you must assess the patient's muscles when they're animating. Then you will know where the attachments are, and you can then do proper injection for the patient. Why is it moving on its own? Now this next patient, same. When the patient frowns, you can see short, strong corrugator, probably a bit stronger on the left again as compared to the right. Strong procerus muscles. She also has got depressor supercilii on both sides of the face. So you have to treat procerus, corrugator, medial, lateral end. You also treat the depressor supercilii. Now, this case, a very young lady, hardly any procerus. Why? Because there's no horizontal wrinkle on the nose. She has very short corrugator, stronger probably on the right as compared to the left. Can you see that? Okay, no horizontal line on the nose bridge, so the procerus is not strong. Let's take a look at the next case. Alright, so this case, again, you can see hardly any procerus, strong short corrugators. Okay, in this case, you can do less dose in the procerus. You can even do a 3-point injection for this patient. Okay, instead of 5-point. If you do a 5-point, you can actually do procerus, the head of the corrugator, maybe a 10 units. The tail you can do a 2 to 4 units. And that's what you do when you see muscle pattern like this. Now, this is the omega sign. So how does omega sign happen? We know that the corrugator supercilii draws the medial end of the eyebrow downwards and inwards. So initially when the patient frowns, the medial end of the eyebrow goes downwards and inwards. As the patients continue to frown, the central medial portion of the frontalis muscles is very strong. It draws the medial ends of the eyebrow upwards, resulting in this omega sign. So what does it tell you? It tells you that the corrugators are strong, procerus a bit weaker. It tells you that the central portion of the frontalis muscles is strong. So what do? You probably have to inject the central portion of the frontalis muscle. You definitely have to treat the corrugators. Okay, so that's how you analyze muscle pattern to decide what you must treat to give the best results to your patients. You don't just give the standard dose, 5-point injection, 3-point, and then the forehead lines, because there's a difference between good injectors and so-so injectors. So you want to be excellent injector, you need to be able to analyze the muscle pattern of your patient. Now, this case is inverted omega sign. So inverted omega sign means what muscle is strong? Can I have a show of hand? Who can tell me? When you have an inverted omega sign, which muscle is the strongest? Exactly. Did I hear procerus? Yeah, procerus is the strongest. Very good. So listening. Why is procerus strongest? Because you have this horizontal line on the nose bridge, okay? The corrugator, it's not so strong. This is stronger. And this patient also has a very interesting insertion of the orbicularis oculi into the medial canthal tendon. Alright? So she has got bunny lines, which you have to treat when you're seeing patients like this. Okay, so this again is inverted omega sign. I won't bore you with them. You know already what is the mechanism of action in different muscles. Let's talk about orbicularis oculi muscles. Now the orbicularis oculi muscles consist of two portions, the orbital portion and the palpebral portion. The palpebral portion, which is here, is responsible for blinking, for protection of the cornea and for tear production, and the orbital portion is responsible for the lateral canthal line, for winking at handsome men, pretty women, and also in squinting and smiling. Alright, so that's the difference. But what I want to point out to you is this: the muscles do not act on its own. You take a look at the muscles that's attached to the orbicularis oculi muscles. You have the zygomaticus major, zygomaticus minor, you have the levator labia superioris, and you have the LLSAN, which is the levator labii superioris echinacea. So what does that tell you? When you're injecting the lower canthal point for treating lateral canthal line, you want to make sure you inject above the inferior border of the zygoma. You want to inject superficial and not deep. Otherwise, if you're too low, too deep, you're going to hit the zygomaticus major muscles and you're going to result in an asymmetrical smile. So the best way to manage any complication is to prevent it from happening in the first place. And the best way to prevent complication is to understand facial anatomy, in this case, muscle facial anatomy. That's why it's important for you to understand all this. Otherwise, everything that you learn is head knowledge. Now, these are the different patterns for the crow's feet. You can take a picture of that. So that only tells you which part of orbicularis oculi muscles is strong. Okay? Now, let's take a look at the few patterns of crow's feet. You have a short pattern and you have a very long pattern, which we see in Jeffrey. Today, the pattern is shorter because she was just injected. Now, when you see radiating lines of lateral canthal lines like this, okay, there are a few things you need to take note. One, when you're injecting lines like this, on labor, you do 3 points. Okay? From my clinical experience, of course not recommended by the company, I will do 2 rows. Why is that so? Because basically, you want to flood the neuromuscular junction with the toxins in order to give good results to your patients. So I'll divide the 30 units into 2 rows to flood. And remember, you don't chase lines like this, because if you inject below the inferior border of the zygoma, you might cause complications like asymmetrical smile. That's why, again, important for you to understand. So the patient is going to ask you, I have lines like this, what am I going to do? So what are lines like this caused by? Lines like this are caused by repetitive muscle movement. They are happy people. Photo damage, loss of collagen and elastin. One of the best treatment you can perform for lines like this is actually Profilo. You either do Profilo 64 or you do Profilo Structura. Excellent treatments for lines like this, accordion lines, and to improve skin quality. In other words, if you see a lot of static lines, you need combination treatment. So this patient, a full fan pattern for the lateral canthal line, and take a look at the insertion of the lines to the medial lateral canthal. and take a look at the Barney lines of this patient. You need to treat the lateral canthal line, you need to treat the Barney lines, okay? Okay, this is a central fan pattern in this patient. Now we'll talk about forehead patterns, very interesting. So frontalis muscles, we've mentioned, it is the only elevator of the eyebrows. And the frontalis muscles arises from the galea aponeurotica that connects to the occipitalis muscles in the scalp, and it is inserted into the skin and subcutaneous tissue around the eyebrow. And the frontalis muscles do not act on its own. Always remember, it interdigitate with your orbicularis oculi muscles, the corrugator supercilii muscles, depressor superciliis muscle, and also your procerus muscle. So when you're injecting, you need to assess your patients, okay? So these are the different patterns of forehead lines. So why is it important? It is important because you will then understand in the patients with horizontal forehead lines extending across the forehead, they have frontalis muscles that extend across the full forehead. In patients with a V-shaped pattern, you know that the central part of the forehead is devoid of muscles. In patients with central portion, the lateral part of the forehead doesn't have any frontalis muscles. In patients with lateral pattern, the center part of the forehead and the lower center part of the forehead is devoid of frontalis muscles. So what do? What you do is, you will actually use less toxin in cases like this, because you do not have to inject when there's no frontalis muscles, right? You only inject these points. In patients with central portion, you only focus on the central portion. In patient with a full forehead pattern, you need to inject across the whole forehead. Otherwise, you're going to cause Mephisto sign. And I'm going to describe to you what is Mephisto sign later. So you will use less toxin in some cases, so you save more money. So it depends on how you charge your patient. I charge per area, so when I use less toxin, I still charge the same price. But importantly, you know how to analyze the muscles and you deliver good and safe results for your patients. Now let's take a look at forehead lines. Now you can see when this lady elevates her forehead, which side of the frontalis muscles is stronger, left or right? Who says left? Put up a hand. Who says right? Okay, good, you're listening. So we can see the right side of the frontalis muscle is stronger. Why? She has more lines on the right side. Okay, you also take a look at the insertion of the frontalis muscles above the eyebrow. Alright, it's important for you to understand and analyze where the frontalis muscles is inserted. Let's take a look at the next case. Now this is a very interesting case. If you see a patient like this with multiple rows of low-lying forehead lines, and the patient has droopy upper eyelid, the patient has dermatochalasis, photo damage, and the patient is using the frontalis muscles to actually elevate the eyelids to prevent visual obstruction, you want to be very careful when injecting patients like this. You either don't treat, okay, or if you treat, you need to manage patient expectations. You have to tell the patient you inject very high up, more than halfway above the forehead, and you have to inject very superficially in order not to drop the eyebrow and the eyelid, resulting in brow ptosis and eyelid ptosis. Okay, so for forehead lines like this, what do you do? What do you tell the patient? Again, you need combination treatment to improve the skin quality. You need profilo structura. You need skin quality treatment like skin boosters in order to improve the forehead skin quality and elasticity. Again, take a look at the insertion of the frontalis muscles. It is below the eyebrow, and it tells you if you're injecting the lateral canthal line, you do not put the injection point too close medially, because you're going to hit the frontalis muscles and it's going to result in eyelid ptosis. So eyelid ptosis can be caused by treating not only the glabellar complex, but also from treating the forehead and the lateral canthal line. So that is how it happens, okay? Again, another lady, you can see multiple rows of low-lying forehead lines, and this is due to the frontalis muscles being very, very active. Okay? Again, you can see the insertion of the frontalis muscles above the eyebrow. Now, photographic documentation. Now, can I have a show of hands who take before and after pictures before any injectable? Who takes photo before injectable? Very good. Who do not take photos of a patient before any injectable? The rest don't inject. Okay, I'm kidding. Anyway, in my clinical practice, I take before and after photos of all my patients who do botulinum toxin injection and dermal filler injections. Okay, in my practice, no photo, no treatment. I will tell you why. Number one, you want to document any pre-existing asymmetry. Sometimes you miss them out. Sometimes the patient is pre-existing brow or eyelid ptosis on one side, and after injection, the patient come back and tell you, you caused a complication. But if a photo before, you'll be able to tell whether it is caused by you or the patient has a pre-existing problem, because this is actually medical legal. Okay, so you take, this is a video which I don't take for my patients. Every single patient I take because it's a presentation. You want to take before and after pictures like this for your patients, okay? Consistent photography to show good before and after results, especially if you're doing training. Alright, now, complications. We come to the last part. As I mentioned earlier, the best way to manage any complications is to prevent it from happening in the first place. And understanding facial anatomy, especially muscle anatomy, is crucial when you come to injecting botulinum toxin injections for your patients. And this is one of the best ways to actually prevent any complications. So, complications very often happen because of injection technique and the injector. Because the injector do not have a clear understanding of facial muscle anatomy. Sometimes, of course, you are very good, but unfortunately there's unusual and anatomical variance in your patients, okay? But you learn about it, and the subsequent treatment you become better. Very often it's due to you either using wrong dosages, injecting at the wrong site, wrong depth, or you're injecting too fast, okay? Of course, if you use unregistered product, which I understand is available in Vietnam. Now, using unregistered product is like that, right? If you use unregistered product, 0.05 mils give you 5 units of Dysport instead of 10 units of Dysport, you're fine, because the most is the patient has not optimum results. But if you use 0.05 mils, it's the unregistered product, gives you 20 units, then you're going to cause a lot of complication. And that's the reason why using registered product for your patients is very, very important. Okay, now no systemic toxicity has been reported for using approved doses and registered products for aesthetic purposes. And for therapeutic purposes, Dysport above 1,500 units, the safety and efficacy has not been proven. So anything less than 1,500 for therapeutic users is safe, is proven in studies. Anything above it, you're on your own, because the company has not done studies to prove that it's safe and efficacious. So these are some of the complications. I won't bore you with them. I'm just going to, you can take a picture of this. I'm only going to share with you some of the more important complications. Now, the first complication I'm going to talk about is accentuation of untreated wrinkles. This typically happens when you're treating glabellar frown lines and lateral canthal line. There's recruitment of muscles, of the nasalis muscles or the LSAN. It often happens in patients with flat nose bridges, either of African descent or Asian descent. So you want to either prophylactically treat the bunny lines when you're treating glabellar frown lines and lateral canthal line, or if it happened already, you can just put a few units of Dysport at the nasalis muscles to correct these bunny lines. Now, the second complication I'm going to talk about is the pseudo Mephisto sign or the Mephisto sign. Now, the quizzical loop can be divided into two types depending on the mechanism. For the pseudo-Mephisto sign, you see when the patient is elevating the eyebrow or when the patient is at rest, and pseudo-Mephisto sign happen when you're treating the glabellar complex. You inject the points too high up. What happens is you hit the lower central portion with frontalis muscles, you paralyze the medial fibers, the patient is unable to lift the medial ends of the eyebrow, so there's sagginess of the medial brow. Whereas the Mephisto sign happen when you're treating the forehead lines. Okay, you treat the center part of the forehead, you insufficiently paralyze the lateral fibers, as a result of which, when the patient raises the eyebrow, you have the spot brow look. Okay, so what is the pathogenesis of the pseudo-Mephisto sign? Remember, I explained to you the frontalis muscles that elevates the eyebrow and the depressors of the brow, i.e. the corrugator supercilii, depressor supercilii, and the procerus, they all interdigitate with each other at the medial ends of the eyebrow. Okay, they all are together. So when you're injecting the glabellar complex, here, instead of injecting at the tail end or at the medial end, you inject too high up and you inject too deep, you're going to hit the frontalis muscles and the patient is not able to raise the medial ends of the eyebrow, and it results in a Mephisto sign when the patient raises the eyebrow. Pseudo-Mephisto sign. So to correct the pseudo-Mephisto sign, you want to prevent it from happening in the first place, so make sure you do not put the injection point too high up, because this will hit both the corrugator and the frontalis muscles. You want to move the points down, medial head and the lateral end of the corrugator, alright? And when it happens, it's very easy to correct this. You just put a few units of Dysport at the point of maximum contraction when the patient raises the eyebrow to correct it. Now let's talk about the Mephisto sign. Mephisto sign happens when the patient has a very wide forehead, because remember the frontalis muscles across the whole forehead, and you treat the medial fibers, you insufficiently paralyze the lateral fibers. So what happens is when the patient raises the eyebrow, there's a spot brow. Okay, so to correct this, it's very simple. You prevent it from happening, you make sure you treat the entire forehead. And if it happens, you want to correct this, you just put a few units of Dysport just above the spot brow. Okay? So this is to show you before and after, how the patient looked after correction. Now let's talk about eyebrow ptosis. Eyebrow ptosis occur at an incidence of 1 to 5% in many clinical studies. And eyebrow ptosis, again, is very often due to us, the injector and injection technique. You either use incorrect injection sites, you use too high dosages, you inject too fast, or you select the patients wrongly. So what are the risk factors for eyebrow ptosis? Remember what I said? If a patient is older, has got photo damage on the forehead, has dermatochalasis of the eyebrow, and the patient is using the frontalis muscles to open up the eyes to prevent visual obstruction, you want to be very careful. You either totally avoid, or you put low doses intradermally, superficially, very high up on the forehead. I mean, bring the patient back in 2 weeks for review. If you need to top up, you top up then, because what you put into the patient's face, you cannot take it out after injections, okay? And in patients with very low set eyebrow, you want to be careful. Patients with previous surgery, neuromuscular condition, myasthenia gravis, patient with previous history of ptosis, you want to be very careful. And of course, these are due to the injectors, as I've mentioned to you. Now, so a very typical case, dermatochalasis, a lot of photo damage on the forehead, patient is raising the eyebrow to prevent visual obstruction. You want to be very careful. So I've mentioned again, you see patient like this, either you totally don't treat, tell the patient you can treat, inject high up, superficial, low doses, combination treatment, Profilo, Profilo Structura, excellent for multiple rows of forehead lines, but not at the same sitting. You do the toxin injection first, bring the patient back 2 weeks for review, and then you put in your Profilo, Profilo Structura, your skin booster treatment. Okay, now accentuation with infraorbital bags, malar, edema, and lower eyelid edema. This happens when you're treating the lateral canthal line, the orbicularis oculi muscles. Now, when you inject, especially the lower canthal line in patients with pre-existing malar edema, you can actually worsen the malar edema. Why? Because the lymphatic vessels of infraorbital area is very, very delicate, and the orbicularis oculi muscles actually has a pumping action to improve the lymphatic drainage in the infraorbital area. If you inject in the infraorbital area to relax orbicularis oculi muscles, you can actually worsen infraorbital fat herniation, worsening eye bag appearance. You can also decrease the lymphatic drainage in the infraorbital area, worsening malar mount and malar edema. Okay, so how do you prevent this? When you are consulting the patients, you always ask the patient, when you wake up in the morning, do you have this puffiness in the under eye, especially if you've taken a very saltish meal the night before, like you take ramen, you take very saltish pho, you drink a lot of alcohol, and you wake up with puffiness in the under eye, you want to be careful. So what do? You either avoid the lower canthal points or you reduce the dose, okay, in order to allow the orbicularis oculi muscles to work, to pump the lymph, and to actually make sure that the muscle is not too relaxed. Okay, so this is malar mount, malar edema, and this is what you can do to correct. And if it does happen, you need to either tell the patient to wait, or you can do radiofrequency or microneedling radiofrequency treatment. Now, eyelid ptosis. Eyelid ptosis is very, very rare. It occurs at a percentage of less than 1 to 2% in multiple clinical studies. And eyelid ptosis, I mentioned to you, can occur when you're injecting the glabellar complex. It can also occur when you're injecting the frontalis muscles, right? It can also happen when you're injecting, actually, if you're very not careful, the medial end of the orbicularis oculi muscles. And eyelid ptosis, a diagnosis is made if the distance between the lid margin and the pupillary light reflex is less than 2.5 mm. So normally it should be 2.5. If it is less than 2.5, you have eyelid ptosis. Or the difference between the two eyes is more than 1 mm. So the definition of eyelid ptosis is made. Eyelid ptosis can happen 48 hours or 1 week after injection of the glabellar complex. Unfortunately, if it happens, it's very distressing to the patients, and of course stressful for you. It can last for weeks. Okay, so you want to be careful in patients with pre-existing eyelid ptosis, and you want to assess the patient. You want to take good photographs before you start the treatment. Now, how does eyelid ptosis occur? Eyelid ptosis occur when you're treating the glabellar complex because of spread of the toxin through the orbital septum, through the supraorbital foramen, supraorbital notch, supratrochlear notch and foramen into the levator pulmonaris superioris muscle, and this muscle is required to raise up eyelid. So when this is hit, you have eyelid ptosis. Okay, this is the mechanism of action. Right? So to prevent, what do? You can block the supraorbital, supratrochlear foramen with a non-dominant finger when injecting. You want to inject slowly, small volume. Remember, I tell you, precision is important when you're doing botulinum toxin injection. Okay, you have to be very, very precise, which is why I urge all of you again to use a 0.3 mil syringe, because you need to be very precise when injecting this area to prevent complications. You want to inject the head of corrugated deep, lateral and superficial. Don't rub the eyes 4 hours after injection. If it does happen, you know patient has pre-existing history. Instead of 5 points, you can do 3 points injection. Now, when it happens, what do? Besides the levator pulmonaris superioris muscle, there's another muscle known as Muller's muscle, which is the upper portion of tarsal muscles that help to lift the eyelid. Now, the Muller muscle is not mediated by acetylcholine, so it is not affected by botulinum toxin injection. So what you want to do is to use an eye drop with an adrenergic effect to activate the Muller's muscle. So what can you use? You can use iapodine eye drop. You can use phenylephrine eye drop. You can use apnic oxymetazolane, but this is only available in US. You can use bromonidine gel, which is mofosol gel used to treat rosacea produced by Galderma. This is off-label, of course, because somebody wrote a paper on using this gel to treat eyelid ptosis. If you're interested, I can send that to you. And of course, you can ask the patient to exercise the beta muscles by closing the eyelid tightly, 10 seconds, open up widely 10 seconds, you do 10 sets a day. Now, another way to treat eyelid ptosis, in Chinese we call it 毒攻毒, okay, is to inject the upper eyelid, which is the pretarsal portion of the orbicularis oculi muscles. Now, the pretarsal portion of the orbicularis oculi muscles is responsible for eyelid tone and the sphincteric activity of the eyelid. So when you inject toxin like this, one unit in the pretarsal portion, very, very superficially, you relax the sphincteric activity, the eye will open up. However, this is of course off-label indication, not approved by the company. But if a patient is very distressed, every day they call you and say, you know, Dr. Chen, my eye, I cannot go to work, you know, how long it's going to be, my husband is going to kill me, my wife's going to kill me. So you are stressed out, you can try this method. However, you need to convince the patient, because the patient has a complication for botulinum toxin injection, and you tell the patient, I'm going to use toxin to correct your complication. You need a lot of convincing, okay? But if you can convince the patient, this will work. Right? So this is 2 hours after putting in the Epidin eye drop, the eyes have opened up, but this needs to be repeated. Now we talk about asymmetrical smile. When you're treating the lateral canthal line, remember I shared with you the orbicularis oculi muscles interdigitate with the zygomedicus major, minor, levator labri superiores, and the LMSAN. So when you're treating the lateral canthal line for the lower canthal point, remember to inject above the zygoma, inject superficial, and make sure you stay high above so that you don't hit this muscle, resulting in asymmetrical smile. Unfortunately, lower face complication takes weeks and months to resolve. So the best way to manage any complication is to prevent it from happening in the first place. Okay, so you don't treat too low. Alright, if it happens, it's really tough. You have to tell the patient not to smile too much. Okay, so best way is not to let it happen. Okay, now in conclusion, we know Dysport approved for glabella is 50 units. It has a fast onset of action, long duration of action. It is safe and it is efficacious. Repeated treatment does not result in any repeated treatment is safe. Okay, Dysport does not have any cumulative adverse events. It does not have any tachyphylaxis issue. And at the approved dose, botulinum toxin has the quantity of active neurotoxin to maintain natural, long-lasting, and durable results. And with that, I thank you.